Hello friends, this is a case of laparoscopic cholecystectomy and appendectomy. This patient has previous episodes of appendicitis and she has also the multiple gallstone with the previous episodes of cholecystitis. So, we are stabbing the inferior crease of umbilicus and then we will introduce the varus needle over the inferior crease. And we have to lift the abdominal wall in such a way that varus needle should be perpendicular to abdominal wall but oblique to the body. And now this is the syringe and this is doing the irrigation test, suction test and then hanging drop test. And then we will start the insufflation. Pressure is kept to 15 and slowly we will wait for pneumoperitoneum to increase so that actual pressure should become the equal to preset pressure. And average amount of gas required is minimum 1.5 liter and maximum 3 liter so that the actual pressure can reach to the preset pressure. So, our eye is on the quadromanometric indicator of the insufflator and we can see that homogeneous distension is already started and abdomen is getting distended with the CO2. After that, once the full distension will happen and the actual pressure will reach to 15 millimeter of mercury pressure, then we will remove the varus needle. So, this is cholecystectomy and appendectomy and both we will perform with the same port. So, we can see now the bulge of abdomen is appreciated and now the actual pressure is almost reached to the preset pressure and now the varus needle we will remove. After that, we will extend the incision to 11 mm. This is a smiling incision. We should increase either side in a smiling fashion and then we will dilate the obliterated vitreointestinal tract and that is a part of a Scandinavian technique and we are dilating the obliterated vitreointestinal tract and then this is the Trocar 10 mm port with the little bit betadine over the tip and then we will introduce the Trocar. So, this is a 10 mm port, that is a telescopic port that is getting introduced. And now as soon as it will enter, this is hissing sound will come and then trocar will be taken out. After that, telescope will be introduced and then this is the GP sternum. With the right thumb we are palpating the GP sternum and the second port will be just 1 centimeter below the GP sternum. This is epigastric port and through that our main working instrument will be introduced. So, through this port we will put the harmonic or you can use hook also and this should go initially perpendicular and then it will puncture the membranous part of the falciform. So, it will go towards the right. And now this is the second port. Third port you can ask your assistant to introduce. This is mid-clavicular line just below the costal margin or if the liver is enlarged then you can put it just below the fundus of the gallbladder. So, this is the third port that will be surgeon's left hand for the atraumatic grasper to give anteromedial or anterolateral traction. Now, fourth port should be anterior axillary line at the level of umbilicus or it may be 7.5 centimeter lateral and below the third port on anterior axillary line. This also you can ask your assistant to put and then assistant will use the atraumatic grasper to hold the fundus of the gallbladder. After that, the patient orientation on the table will be changed, that is head up and the right up. And these all the four ports are in the position and then we will start the cholecystectomy. So, the first step is we should hold the fundus of the gallbladder and we have to retract towards the right shoulder. After that, we will hold the Hartmann pouch with the left hand and then we will do the initial, you can see Rovier sulcus is clear cut visible. And all our dissections should be above the Rovier sulcus. Here we are using the harmonic scalpel and the Teflon jaw of the harmonic scalpel will be towards the gallbladder. Below you can see CBD, this is a Hartmann, this is Rovier sulcus. So, this is the posterior peritoneal dissection is started. And we should only cut the peritoneum, we should try to avoid keeping the Teflon jaw towards the gallbladder. We should try to avoid keeping the vibrating jaw towards the gallbladder, otherwise it will puncture. And slowly at least 1/3 of the gallbladder of the posterior peritoneum should be separated. Either you can use harmonic scalpel or you may use the hook also. This is personal preference. Some surgeons they use scissors as well, and only peritoneum should be cut. And this should be left hand should must give the anteromedial traction so that peritoneum will be exposed and you can cut it. If peritoneum is under tension, there will no any rupture of the gallbladder. If you will keep it loose, then it may puncture. And all our dissection should must be above the rovier sulcus. And this is the porta hepatis, can you see? And this is the rovier sulcus. So, rovier sulcus is separating the right lobe of the liver with the caudate lobe of the liver at the level of porta hepatis. So, this is the posterior peritoneum is dissected. After that, we will give anteromedial traction, and at the same level, this is the anterior peritoneum should be separated. And at that time, left hand must give the anterolateral traction. And we should try to remain as nearer as possible to the liver. However, direct touch of the liver should be avoided. And we can see this way, if you will separate, cystic plate will open and you will get a posterior window. So, you should try to remain in a visible area, and this is slowly enlarging the and anterior peritoneum dissection is carried out. So, it is a combination of blunt dissection, and if the peritoneum comes in the way, then only you can use the energy. And this is the anterior dissection is over. After that, we will scalpelize the cystic pedicle. So, you should hold the peritoneum of the cystic pedicle very thin, and then we should scalpelize it and take care that accidentally the duct or artery should not be damaged. So, very thin flap of peritoneum should be separated, and the left hand should keep the traction anteriorly. And all the activities should must be above the rovier sulcus, and we should remain towards the gallbladder. We can see here posterior window is formed and cystic plate is getting enlarged. So, it is very important that you should separate the peritoneum, because without cutting the peritoneum, if you will try to separate the duct and artery, it will puncture. So, just a millimeter of the peritoneum should be held, and then bluntly you can push it down. So, this is the bluntly you can push it down. And now after that, we have already injected 1 ml ICG just 45 minutes before the surgery. So, you can try to turn the ICG mode on, and you can have a anatomy you can see. So, we can see this is CBD, and then ICG mode is on. This is the common hepatic duct, this is the right and left hepatic duct, and this is the cystic duct which is clearly visible. After that, we will now, this is the posterior window is confirmed by opening the jaw of the Maryland, and we can see this is the inferior surface of the liver is visible. After that, you can just open the Maryland in the direction of the tubular structure. Always Maryland tip should be opened in the plane of the tubular structure. We should not open it at right angle. And after that, we will hook the duct by turning the Maryland, and this is the anterior window is formed. So, this is cystic duct and behind is the artery, and this is the critical view of safety. We can see this is anterior window and behind is the posterior window, and now it is fully conformed. And again you can turn the ICG mode on, and you can look at the duct and the CBD clearly. After that, we are clipping the artery, and both the limb of the clip applicator should must be visible, because we are using harmonic. So, one clip on the artery is enough, and after that you can clip the duct. So, first clip will be towards the CBD, but it should not do the lateral clipping of the CBD. So, remain at least 3 millimeter away from the CBD, and after that we will apply the third clip. So, this is the first clip, and then we will apply 9 millimeter away, we will apply the third clip. So, this is the third clip, and then we will sweep the back of the cystic duct by the jaw of the clip applicator, and then this is applying the second clip. That should be 3 millimeter away to the first clip. After that, here we are using the scissors to cut the cystic duct. You can use harmonic also, but direct touching of the harmonic to the clip should be avoided. And that's why this is the scissors which is cutting the cystic duct. And after with the harmonic, you can coagulate the cystic artery just above the clip which you have applied over the artery. At that time, you should relax the Hartmann pouch so that artery will seal. Then now it is over. After that, we have to separate the gallbladder from the liver. So you should catch just below the clip so that clip should not get disengaged, and slowly a areolar tissue plane should be achieved and the gallbladder will be separated from the liver. During that, your left hand should give the gentle traction and anteromedial and anterolateral traction should be given to get a complete areolar tissue plane. And first we should catch the peritoneal, that is called shoulders of the gallbladder, and then only you should have a good areolar plane. We should try to avoid the parenchyma of the liver, but very thin gallbladder sometime in the soft liver. If it is detaching, then we should try to avoid it. And as soon as right now the light cable of the your camera of 30 degrees should be down, and then the fundus grasper now is removed because now it is not necessary, and the final dissection of the fundus of the gallbladder will be carried out. And it should be a combination of gentle traction and the blunt dissection. Only peritoneum you should try to cut it sharp, and slowly this is the final dissection is carried out. So we can see this is the final dissection, and before that you can have a final inspection, and then gallbladder will be separated from the liver. And once the gallbladder will be separated, then we will keep it on the Morrison's pouch and we will transfer the telescope to the epigastric region. So cholecystectomy is over. Now we will put the gallbladder on the Morrison's pouch on subdiaphragmatic area and then transfer the telescope to the epigastric region, and then with the mid-clavicular line instrument you can hold the appendix and anterior traction will be given. This is the major appendix dissection, and slowly you should go up to the base of the appendix up to the tinea coli, so that it should be fully skeletonized. Care should be taken that this vibrating jaw of harmonic should must be kept towards the under vision, so that accidentally you should not touch the ilium or you should not touch the cecum. And we should must reach up to the base of the appendix so that there should not be any incomplete appendectomy. So we can see this dissection is almost over. This is tinea coli and the cecum is visible and the appendix is skeletonized. After that we are using here the Misra's knot with the Van Darker knot pusher, and this is the knot tightened. But we can see this knot is not up to the base, so we will use one second knot also, and that will be on the base of the appendix. So the second knot should must go up to the junction of the cystic duct with the cecum. For that you should keep the tip of the Van Darker knot pusher over the cecum, so that you should take the complete appendix, and it should not be incomplete appendectomy. So this is the second knot applied over the base, and after that appendix will be detached from the cecum. So here also we should take care that your harmonic should not cut the suture, and this appendectomy is also done. In front of the knot 3 to 5 millimeter of stump only should be left, and it is over. After that we will take a claw forceps, and with the 10 mm port you should hold the appendix longitudinally. It should not be transverse arrest, and the appendix is removed. After that this gallbladder also neck will be taken into the cannula, and then cannula also will be removed. And here we are using suction to suck the gallbladder, and we can see there are hundreds of stone in this patient. So what we should do first, we should take a ovum forceps, excise the neck of the gallbladder, and with the ovum forceps one by one we should evacuate all the stone out and then only gallbladder will come out. So, this is Ohm forceps which is emptying the gallbladder. Alternatively, you can use a endo bag, and this is a very young patient, and in this we are not using endo bag. So, there is no suspicion of the malignancy, and it is not a acute case. So, there is no any inflammation or infection. So, here without endo bag we are evacuating the gallbladder stone, and then gallbladder will be easily taken out. So, we can see now all the stone one by one is pulling out, and once it will become empty, then easily you can pull it with the 10 mm wound. So, now the gallbladder is out. After that, you should clean this epigastric port with the irrigation, so that any bile or any other tissue or fragmented stone should not be there. So, it should be nicely cleaned, because that can create sometime the infection. So, it should be nicely clean, and this is over. So, thank you very much for watching this video.